Clinical Focus with Manda and Ben. Bringing you weekly reports on clinical anatomy. Alright guys, welcome to Clinical Focus, week 5 I believe, Manda. I could be wrong there, but I think it's week 5.
That's right, you're right.
Yeah, so today we're going to be talking a little bit about the abdomen. We actually haven't touched on the abdomen yet, so there's a huge amount of things we can talk about, but we're going to focus to kind of the principles of the abdominal wall and some of the structures below.
Yeah, you're right. So, firstly, let's start with the anterior abdominal wall, and namely the fascia of the anterior abdominal wall. And the superficial fascia of the abdominal wall is usually divided into 2 layers. It's called the superficial fatty layer of the superficial fascia. It's called the Camper's fascia, which is continuous with the superficial fascia of the thorax and thigh. And the other layer is the deep membranous layer of the superficial fascia, also known as Scarpa's fascia. Now, this layer, Scarpa's fascia, is quite important clinically because this layer is continuous with the superficial fascia of the penis, the scrotum, and the perineum. And it's quite important during surgery as well, because if you do surgery in the abdominal wall and you cut the anterior abdominal wall and then you remove an organ or you repair damage and then you suture back the layers, it's quite important that usually surgeons, they include the membranous layer of the superficial fascia for added strength when they suture back the incision. And also if you have blood or urine in the lower anterior abdominal wall or the pelvic region, usually this abnormal accumulation of urine or blood is found deep to Scarpa's fascia. So again, it has some clinical applications.
Okay, so the first thing we're going to consider here in the abdominal wall, though, is we're going to look at some muscles, I think, Manda?
Exactly. So if you look at the anterior lateral abdominal wall, there are a few muscles that we need to know about. One of them, or the most external one, is the external oblique muscle, and then deep to that is the internal oblique muscle, and the innermost muscle is the transversus abdominis muscle. Now, anteriorly and in the midline, we have the rectus abdominis muscle, which is divided by these transverse tendons into, I think, how many segments? Ben?
Well, it depends on the person, but
Exactly.
we can have anywhere from 3, maybe sometimes 4 segments.
That's right. Yeah, and again, it's important to know the nerve supply of these muscles. Now, if we talk about the
maybe we can sort of mention
Yeah.
something about the muscles. Now, we would have all spoken about the thorax a bit, and we did speak earlier about the thorax, but we can sort of liken these muscles, these 3 layers of muscles, to the 3 layers of muscles we saw in the thorax area. We've got an external oblique, which would be likened to the external layer of muscles in the between the ribs, the external intercostals. We've got the internal obliques in the just below the external oblique, and they we can liken maybe to the internal intercostal muscles. And then we've got the transversus abdominis, which we can, to some degree, to a lesser degree, which we will discuss, to the innermost intercostals. And we can say this because we can sort of see that the directionalities of the muscle fibers kind of work at 90 degrees to each other to the most extent which we saw in the thorax, and that there are a few clinical significance aspects we can discuss about that. But we might start with the external obliques and look a bit into them.
Yeah, so the external oblique abdominal muscle, as been mentioned, the fibers of this muscle, they usually run inferior medially. It's like putting your hand in your pocket. This is the direction of the fibers.
And is that the same direction as the external obliques in the thorax?
Exactly, it's the same. It's the same direction of fibers. Now, the internal abdominal or the internal oblique muscle in the abdomen, the direction of the fibers, they run 90 degrees to the direction of fibers of the external abdominal muscle. And they have the same direction as the internal intercostal muscles as well.
And the thing is, one of the clinical significances of this is if we have two muscles that run in different directions to each other, they form. There's usually a quite a thin areola tissue that runs between them, so the muscles themselves aren't infused together, so they're quite easy to split during surgeries, and that's quite significant when we're going to go in and move muscles apart in the abdominal wall, as opposed to the situation where we might have two muscles that run along with each other in the same direction, such as the presence of a psoas minor, where the muscles actually infuse together. And you see this a lot in the forearm as well, and they're actually quite hard to split.
That's right. So if you want to make an incision in the anterior lateral abdominal wall, your first incision should follow the direction of the fibers of the external oblique muscles, and then as you separate these fibers and you expose the internal oblique muscle, and then you make another incision perpendicular to the incision that you've just made, just to separate the fibers of the internal oblique muscle.
So we know that the external obliques, they run 90 degrees inferomedial, so they're kind of like putting your hands in your pocket. We mentioned the internal obliques being that they run 90 degrees to this, so they kind of run in a directionality where you're going superior and medial as well, so 90 degrees to that. And then we have the transversus abdominis, which...
Yeah, usually the fibers of which they run either like horizontally or they follow the direction of the internal oblique muscle. There are a lot of variations with regard to the transversus abdominis muscles, but again, the important thing to remember is that the neurovascular structures, the arteries and nerves that they supply the abdominal wall, they usually run between the internal oblique and the transversus abdominis.
Yeah, so they run between layers 2 and 3, and as we've been saying, the theme so far is that it's very similar to what we see in the thorax, where the nerves and the vessels, the intercostal nerves and vessels, they run between layers 2 and 3.
Exactly. And the muscles of the anterior abdominal wall usually innervated by the thoraco-abdominal nerves or the intercostal nerves from T7 to T11 or 12. T12 separate nerve is called the subcostal nerve. Some innervation is also received from the iliohypogastric and the ilioinguinal nerves.
And they come from which spinal region?
From L1.
Yeah, so they both come from L1.
Now, let's talk a little bit about the arterial supply of the anterior abdominal wall. Now we have the superior epigastric artery, which is the terminal branch of the internal thoracic artery that descends in the rectus sheath to anastomose with the inferior epigastric artery around the level of the umbilicus, or probably just superior or inferior to that. And the inferior epigastric artery, which arises from the external iliac artery and ascends medial to the deep inguinal ring to enter the rectus sheath. And again, some clinical and surgical applications of the inferior epigastric artery is that sometimes there is an abnormal obturator artery, which is endangered during femoral hernia repair surgery. And this artery, the abnormal artery, arises from the inferior epigastric artery, and it passes very close to the femoral ring. So if we have femoral hernia, this hernia usually passes through the femoral ring, and if you want to repair this hernia by cutting the femoral ring, just be mindful that this artery might be present there, and it might cause problems in terms of profuse bleeding. This is not common, but you need to be aware of this. And actually, this is a very good exam question, so just know this fact. Now, in terms of the venous drainage of the anterior abdominal wall, we have collateral connections between tributaries of the superior vena cava and the inferior vena cava. So superiorly, we have the thoracoepigastric and the superior epigastric veins. So they drain blood from the superior part of the anterior abdominal wall. And then again, inferiorly, we have the inferior epigastric veins. So, and these veins, they anastomosis around the region of the umbilicus. So, in such conditions, like the cirrhosis of the liver, in which we have portal hypertension, so what happens is that the blood is backed up all the way through the inferior vena cava and goes back through the superficial veins, and that's why we have enlargement and congestion of these superficial veins in the anterior abdominal wall. And this condition is called the caput midosi, which is very indicative of liver cirrhosis and portal hypertension in particular.
Okay, so maybe we could kind of put all this kind of knowledge together and look at what layers we'd traverse if we were just going through the abdominal wall. So Amanda spoke at the start about the scarpas and campus fascia, the subcutaneous tissue below the skin. So if we're going through, let's just say, the anterior abdominal wall through maybe a little bit lateral to the rectus abdominis, we'd start by going through the skin. We'd hit campus fascia, which is the fatty part of the subcutaneous tissue. Then we'd hit the scarpas fascia, which is deep membranous. So it's kind of the thicker part, and it can be mistaken in some surgeries by people who aren't kind of thinking about it for maybe the external oblique ponuresis, so the tendinous part of the external oblique. So that's something to consider. And then, deep to this, we obviously have the muscle, the external oblique, maybe the aponeurosis, depending on how far medial you are. And then you've got the tissue between, obviously, but then we have the internal oblique, the transversus abdominis, and then you kind of have a transversalis fascia, which is an endothoracic fascia that is seen throughout the entire body. We have endothoracic fascia that's in the thorax and other parts of the body as well. So that's what you would expect. Then you have a little bit of fat, so the extraperitoneal fat, so outside of the peritoneum, and then obviously we have the peritoneum.
Exactly, and the peritoneum is usually arranged into two layers. You have the parietal peritoneum and the visceral peritoneum, and it's the same in the thorax. In the thorax, we talked about the pleura, the parietal pleura, which lines the thoracic wall, and the visceral pleura, which covers the thoracic organs. In the abdomen, we have a similar arrangement. So we have the parietal peritoneum, which lines the anterolateral abdominal wall, and then we have the visceral peritoneum, which covers the abdominal organs and viscera. And again, it's important to pay attention to the innervation of these two layers. Now, the parietal peritoneum receives innervation from somatic nerves. These are the same nerves that supply the anterolateral abdominal wall. As we mentioned, these nerves they arise from T7 to T12 and sometimes L1 part of the spinal cord. Now with the visceral, so if you have irritation or damage to the parietal peritoneum, then you perceive that as a somatic type of pain, which is like sharp pain, well localized, that is worse on movement of the abdomen. And these are signs that gives you an idea that the parietal peritoneum is involved in whatever pathology the patient is presenting with. Now, on the other hand, the visceral peritoneum receives innervation from a autonomic nervous system, and this means that you don't feel sharp pain, well localized pain, but instead you feel a vague sort of aching type of pain, poorly localized, and this type of pain is usually corresponds to the part of the GI tract, and we can divide the GI tract like embryologically into three parts, being the foregut, the midgut, and the hindgut, and pain perceived from each part of the gut is received from a different part of the anterior abdominal wall.
So maybe we could just quickly mention the different levels at which we see those differentiations. So we have the foregut, which runs from
Yeah, so the foregut actually starts with the beginning of the esophagus.
The abdominal esophagus.
Yep. And it goes all the way until the middle of the second part of the duodenum. And then the midgut starts from the middle of the second part of the duodenum and goes all the way until the splenic flexure of the transverse colon.
Very, very close to the splenic
Exactly.
flexure. Yeah.
And then the hindgut, which is the remaining of the large bowel all the way until the dentate line of the anal canal.
Now, they'll all have their own different supplies, so their blood supplies will be very different to each other, and it's kind of a functional way of dividing up the abdomen. But the one that's kind of clinically significant in this case is looking at the nervous supply. And if we take a clinical scenario where we've got appendicitis, so an inflamed appendix for some reason, we're going to have, because it's attached to the cecum, it comes from the cecum, we know is going to be part of the midgut. So midgut structures are going to be referred to the periumbilical region, so the region around the umbilicus. Now, because we're going to have kind of an autonomic nervous signal from the appendix, we're going to have referred pain, and referred pain from a unpaired structure we know goes to the midline because it receives both the left and right nerve innervations which fire at the same time. Therefore, we get pain being referred to the midline. But what we see with appendicitis, and what you can see clinically, is the pain will start in that midline around the umbilicus, but as the condition worsens, we've got the inflammation kind of irritating the parietal peritoneum, which causes more localized pain, because now we've gone from having a visceral pain to more of a somatic pain that can be localized to the peritoneum. So we see the pain move from the umbilicus across to the right iliac fossa amongst the skin, and the patient usually will say that they've got very specific pain in that area.
Exactly, that's absolutely right. And with regard to the other parts of the GI tract, like with the foregut, so pain involves or foregut structures is usually perceived as pain in the epigastric region or the upper part of the abdomen. Pain from the midgut, as been mentioned, including the appendix, is perceived in the area around the umbilicus. And pathology that involves the hindgut causes pain perceived in the hypogastric region, just above the pubis. And this actually brings us to the topic of how can we divide the abdomen into regions, and what are the organs that we can find in each region, because it's quite important to know what organs are located in each region. This is very applicable in terms of clinical examination.
So we might start with 9 regions, but a lot of clinicians, for sake of ease, might use the kind of 4 quadrant system where we just divide it up with 2 lines. But for the sake of what we're talking about and dividing it up into epigastric, umbilical, and hypogastric regions, we'll talk about the 9 region scheme. So to divide anything up into 9 regions, we're going to have 4 planes. So we're going to have two vertical planes, and they're very simple, just the planes through the midclavicular line, and they just run down. But then we're going to have 2 horizontal planes. So the first one is going to be the transpyloric plane, which the most accurate way to kind of find that plane is it's halfway between the jugular notch and the pubic symphysis, and we find that way. And that usually runs through the level of about L1, L2. And there's a few things we can find at that region, and we'll talk about that in a sec. But we'll just mention the other plane, which is below that, is the transtubercular or the intertubercular plane. And it's simply called that because it runs between the 2 tubercles of the iliacus, which are just the superior thickenings along its crest. So maybe we might talk about the things we might find at the transpyloric plane.
Exactly. Well, this is very important because when you look at a CT image of the abdomen, and you identify that the level that you're looking at is the L1, L2 level, which is the transpyloric plane, there are a lot of structures that you can find at this level. And it's quite important to know these structures. So just to name a few, we have the fundus of the gallbladder is located at this level. Also, we have the neck of the pancreas, and behind that, or posterior to that, is the beginning of the formation of the portal vein from the union of the splenic vein with the superior mesenteric vein. Other structures that we might find here include the mesentery of the transverse colon. It's called the transverse mesocolon. Other structures we might find here include the hilum of the right and the left kidney. But again, you might read in different books, they say, well, the right kidney is slightly lower than the left one because of the presence of the liver. So
when we take the transpyloric plane through that area, we actually get a superior part of that hilum, whereas we get an inferior part or a lower part of the left hilum of obviously of the left kidney. So that's something that is mentioned, but really for the sake of knowing it for any undergraduate or even postgraduate medical course, it's really just the hilum of the kidneys. And then obviously one other thing to consider is maybe we have the termination of the pylorus of the stomach, but that's so variable between people that you can't say that for sure. I mean, thin people will generally have the termination of the pylorus of their stomach a little bit lower than that. And obviously something that's not mentioned often is the cisterna chyli, which is just the big kind of lymph bulb that collects lymph from the lower part of the body before it sends it up through the thoracic duct. So they're the kind of things we see at the transpyloric plane, and the transpyloric plane kind of divides the stomach. Just above, we have the epigastric area, and we're going to have sides on either side of that epigastric area, which are going to be our hypochondriums. So we have left and right hypochondrium, and in the middle we have the epigastric, because remember we've divided it with two vertical lines as well. Below the transpyloric plane, and just above the intertubercular plane, we're going to have what we mentioned earlier, the umbilical region, and then on either side we're going to have the left and right lumbar regions, because remember, once again, we did divide it with two vertical lines. And then below that intertubercular plane, we're going to have the hypogastric area, and then on either side of the hypogastric area, we're going to have the iliacus, or the iliac areas, left and right, obviously, once again. Now, I think this is a good time, Manda, for us to bring in our kind of challenge for the day.
Exactly.
Now, some people might argue that this is a terrible time because we're halfway through talking about something that's quite significant. But you know what? We beg to differ because we're a risky bunch here. But anyway, that brings us to our challenge. Now, what we want you to do, we want you to email us or send us a message. You know how to get us. We're on clinicalfocus@gmail.com. You can jump on the Facebook group, which is simply facebook.com/clinicalfocus, one word. You don't put spaces in the address bar. And or you can get us on YouTube, youtube.com/clinicalfocus, surprise, surprise. And what we want you to do is we want you to tell us which national anthem is this. Now, don't cheat. You can't look this up on YouTube. But Manda and I are going to give you a hint that it may or may not be one or two of the professors at Monash's favourite national anthems, one of maybe more, but in terms of anatomy, we might see one or two, but we don't want to give you too much of a hint. We're just going to play the first 30 seconds and see what you guys get. Okay, sorry guys, we accidentally left that a little bit too long. Manda and I were having a good conversation about national anthems. So we're back, and we did cut off what we were talking about before, which was dividing the abdomen up into the 9 regions. Now, what kind of organs are we going to see in these 9 regions? Because when we're palpating the abdomen, we've got so many different structures and so many different areas that it's kind of, if we can divide it up in our heads, we can kind of make a guess at what we're going to be feeling in each area and what we expect to feel. So I might start Manda off with looking at the epigastric and the superior parts of those 9 regions.
Exactly. Well, as you mentioned before, when we do clinical examination, it's easier if we think of the abdomen as divided into 4 quadrants, like the right upper, the right lower, and the left upper and the left lower quadrants. And you try, as you palpate the abdomen, searching for any masses, any tenderness, any guarding, any pain. While you look at the patient's face, it's important to visualize what structures lie underneath each quadrant. Now, if we talk about the right upper quadrant, we have the liver, the gallbladder, we have parts of the duodenum as well. We have the pancreatic head is located there. We have the right kidney and the suprarenal gland. We have the right colic flexure or the hepatic flexure. And then we have the ascending colon, the superior part of it, and then the right half of the transverse colon. So if you have, if the patient has pain in the right upper quadrant, so you might think of all these structures as being involved somehow. But again, it's important to mention that if there's an abdominal pain, this does not necessarily mean that you have pathology that involves abdominal organs. Sometimes thoracic organs can give you referred pain in the abdominal region, especially the lower thoracic organs. So, for example, if the patient has a right lower lobar pneumonia, this might present as a pain in the right upper quadrant of the abdomen. So again, it's important to just be mindful of that. And also, it's the same with myocardial infarction. Sometimes in some patients, especially diabetics, the pain is not chest pain, but it's just tenderness in the epigastric region. So your level of suspicion should be very high in those patients. Now, if we talk about the left upper quadrant, again, we have just a small part of the left lobe of the liver in this area. We have the spleen. We have the stomach, the jejunum, and the proximal ileum. We have the remaining of the pancreas, the body and tail. We have the left kidney and suprarenal gland. We have the left colic splenic flexure. And we have the left half of the transverse colon and the superior part of the descending colon. And again, it's important to search for any tenderness, masses, or pain in this region, and just consider these organs as being involved. Now, with the right lower quadrant, we have the cecum, the appendix, the ascending colon, the inferior part of it. We have the right ovary and uterine tube in females. We have the right ureter, the right spermatic cord in males. We have the uterus only if enlarged, and we have the urinary bladder if it's very full. In the left lower quadrant, we have the sigmoid colon, we have the descending colon, the inferior part of it, the left ovary and uterine tube, again in females. We have the left ureter, the left spermatic cord in males, and we have the uterus, again only if enlarged, and we have the urinary bladder if it's very full. Now, it's very important to mention one thing here. If a female of a childbearing age presents with abdominal pain, it's always important to ascertain whether the patient is pregnant or not. Regardless of the location of the pain, regardless of whether there's tenderness or masses or whatever, just make the pregnancy test, do the pregnancy test, and make sure that the patient is not pregnant.
The other point to note there is, where is the boundary of childbearing age? And in clinical practice, you really don't want to say, okay, well, this patient's only 11 or 12 years old, therefore it can't be that. We need to be absolutely certain, because the risk of an ectopic pregnancy or something like that, where the pregnancy is somewhere outside of the uterus, the risks of further complications of that is quite serious. So we need to consider all females of reasonable childbearing age to kind of rule out that diagnosis before we look at other conditions, and that's quite a serious diagnosis. So we try not to jump too much on this show, but we're going to make a little bit of a jump here, I think, to looking at hernias and some things surrounding that. So
Exactly. Now, let's talk about hernias. Now, hernia is defined as a protrusion of a viscous or part of a viscous through an abnormal opening in its coverings or in its walls. Now, there are many types of hernias. We have what's known as the umbilical hernia, inguinal hernia, which further subdivided into direct and indirect. We have also femoral hernia and incisional hernia, which occurs at sites of incisions due to surgical operations. There are less common types of hernia, such as the epigastric or gluteal lumbar type of hernias, really very rare. Now, if we talk a little bit about the pathophysiology of the hernia, like why some patients get hernias, because there's a defect in the abdominal wall, and this defect may be congenital, such as in the situation of umbilical hernia or a femoral hernia, or acquired through an incision, for example. So you have again increased in the intra-abdominal pressure.
And that might be combined with something like a weakness in the wall.
Exactly. Yep. So if you have increased intra-abdominal pressure plus weakness of the abdominal wall, this pushes a viscous or part of a viscous through a weakening in the wall and causes hernia. Now, some of the clinical features of a patient presents with hernia is that the patient presents with a lump over the site of the hernia. And today's topic, we were talking specifically about the inguinal hernia and the two types of it, which is the direct and the indirect. So if a patient presents with a lump in the groin region or the inguinal region, you suspect that the patient might have hernia. Now, it's quite important at this point to differentiate between the inguinal hernia and the femoral hernia. And the landmark to differentiate between these two is the pubic tubercle. If the hernia or the hernial sac is superior-medial to the pubic tubercle, then the hernia is most likely an inguinal hernia. However, if the hernial sac is inferior-lateral to the pubic tubercle, then the hernia is most likely a femoral hernia. And femoral hernias, they are 10 times more common in women than men. So if you have a female patient who presents with a lump in the groin, so your first thought would be a femoral hernia, and you try to rule this out before you consider inguinal hernia. Now, just briefly,
we probably should consider maybe a bit about the kind of prevalence of or the incidence of having a femoral hernia versus an inguinal hernia. So some of the literature does say that femoral hernias might occur 2% of the time, as opposed to an inguinal hernia which might occur much more commonly. But there is a reason why we have to consider femoral hernias, even though they are much more uncommon, and that kind of leads us into the point of strangulation of the bowel in a femoral hernia, where we've got such tight ligaments or such a tight ring around the herniation itself that we get compression of the structure that's going through. So we've got a bit of a small bowel going through the femoral hernia, and if you compress that, you kind of make a neck around it, where the first thing we lose is the venous drainage of the hernia. And if we lose the venous drainage, then we've got arterial supply still going through, so it's going to swell up, and then we're going to get problems with the motility through the hernia. Obviously, nothing can go through, and we can get some serious issues leading even to as bad as necrosis. and that kind of thing. So we have to consider femoral hernias, simply because not because they're uncommon, but because of the consequences of getting one.
Exactly. Well, hernias usually are, if left untreated, and if you do not recognize them quickly enough, they might become life-threatening due to, as you mentioned, ischemia of that part of the bowel herniated through a weakness or abnormal orifice. Now, if we look at the hernia itself, like this segment of the bowel that herniates through an opening, if it's really simple, uncomplicated hernia, we call it reducible hernia, and this means that you can easily push it back to its normal position with your finger. If this is left, the reducible hernia might become irreducible, otherwise also known as incarcerated hernia. And this type of hernia is difficult to push back to its normal position, and you need surgery to correct this hernia. And the most severe type, which is called the strangulated hernia, so if an irreducible hernia is left without surgical treatment, this hernia will become strangulated, and as Ben mentioned, in this type of hernia there's impaired venous drainage, impaired arterial supply, and ischemia of this part of the bowel, and this is it could be a life-threatening situation, because if this part of the bowel ruptures, this can cause to septicemia and bacteremia, which is a systematic severe condition. Now we talked a little bit about the clinical applications of the inguinal and the femoral hernias, but we haven't mentioned anything about the anatomy behind that. So let's talk about the inguinal canal itself. So the inguinal canal is an oblique passage through the abdominal wall connecting the deep and the superficial inguinal rings. So the deep and superficial inguinal rings, they lie sort of above the inguinal ligament, and they transmit the spermatic cord in male and the round ligament of uterus in females, among other structures, of course. If we talk about the boundaries of the inguinal canal, so the roof of the canal is formed by arching fibers of transversus abdominis and internal abdominal oblique muscles. The floor of the canal is formed by the medial half of the inguinal ligament and the lacunar ligament. The anterior wall is formed by the external oblique aponeurosis medially and the internal oblique muscle fibers arising from inguinal ligament laterally. The posterior wall is formed by the conjoint tendon medially and the transversalis fascia laterally. And actually this gives you an indication of which part of the inguinal wall is strong and which part is weak. And by looking at the boundaries, you can easily recognize that the deep inguinal ring is quite a weak structure, because it is guarded only by the transversalis fascia. So if you have a small bowel or part of intestine that is pushed through the deep inguinal ring, through the inguinal canal, all the way, and it exits the inguinal canal through the superficial inguinal ring and presents as a lump beneath the skin in the groin region, this is known as an indirect inguinal hernia. And it is named indirect because it takes an indirect course to reach the skin, a very long path, starting from the deep inguinal ring, the inguinal canal itself, and finishing with the superficial inguinal ring. However, if you have weakness in the conjoint tendon, which forms the sort of the posterior wall of the medial side of the inguinal canal, if you have weakness of this part, then a part of small bowel or intestine is pushed through that, and then it passes through the superficial inguinal ring and presents itself as a lump beneath the skin, and this type of hernia is called the direct inguinal hernia. It's important to know the anatomy of the inguinal canal because again it's relevant to identifying which type of hernia. Is it like direct or indirect inguinal hernia? Anything else that you'd like to add, Ben?
Yeah, maybe we could kind of discuss a little bit about the surface anatomy of where we'd find these structures. So if we were thinking about, let's say, the deep inguinal ring, how do we locate that? Well, we look at a point on the body known as the midpoint of the inguinal ligament, and it is exactly what it is. It is the midpoint of the inguinal ligament, and that's where we will find the deep inguinal ring. And what it is it's the midpoint between the ASIS, the anterior superior iliac spine, and the pubic tubercle. Now, something that people often find confusing is we've mentioned here the midpoint of the inguinal ligament, but we also have the mid-inguinal point, which is very much a different thing. That's the midpoint between the ASIS and the pubic symphysis, whereas the midpoint of the inguinal ligament, where the deep inguinal ring is found, is the midpoint of the anterior superior iliac spine, as is the other one, but it's between that and the pubic tubercle. So there is a little bit of a difference there, and it's a difference in where you also find the nerve and the artery.
Exactly. So as you mentioned, the the midpoint of the inguinal ligament is where you find the deep inguinal ring and the femoral nerve, while the midpoint of the inguinal region is where you find the femoral artery. And actually, this brings us to a very important point here, which is the location of the inferior epigastric artery or vessels. It's very important to recognize that the deep inguinal ring is located lateral to the inferior epigastric vessels, while the superficial ring is medial to that. And this helps you also with identifying what type of hernia you have. Is it direct or indirect? So if the hernia is lateral to the inferior epigastric vessels, then it's most likely to be indirect. If the hernia is medial to the vessels, then it's a direct type of hernia. As I mentioned, just to let you know that the indirect inguinal hernia is more common than the direct hernia, and because with the indirect inguinal hernia, you have a preformed canal for you. So you have the inguinal canals ready for you, and it has two openings, so a viscous can easily pass through this canal and present as a hernia. While with the direct inguinal hernia, you need a weakness in the conjoint tendon, or the posterior part of the inguinal canal, and this happens usually in old males and people who have recent surgeries, or they damaged the nerve supply to the conjoint tendon, and this makes it very weak. So an increased intra-abdominal pressure will push part of the viscous through this weak part of the conjoint tendon through the superficial inguinal canal and presents as a direct inguinal hernia. What else should we talk about?
Well, I guess we can sort of lead into. You mentioned how we've got increased intra-abdominal pressure. Now we've got a canal here, which is maybe the literature argues between it, but let's say for the sake of this show that it's about 4 centimeters long and it runs obliquely and inferiorly. If we increase the intra-abdominal pressure, we're going to get what's called a functional sphincter here, which is where we've got compression that's not due to a direct musculature that's designed to do this. So if we consider what would be the alternate to this, which would be an anatomical sphincter, such as, let's say, the lower esophageal sphincter, where we've got a muscle wrapped around the lower esophagus that is designed to close the esophagus at a point, and that's an anatomical sphincter. But here we have a functional sphincter, which is functionally designed to be compressed or shut in some way.
Exactly. So if you have increased intra-abdominal pressure, then the anterior and posterior walls of the inguinal canal, they just collapse on each other, and they prevent any herniation of any intra-abdominal organs. Now we talked about the parietal peritoneum being innervated by somatic nerves and the visceral peritoneum being innervated by autonomic nerves. Now the point where the parietal and the visceral peritoneum meet each other, you might find what's known as a mesentery. Now a mesentery is a part of a peritoneum that connects a viscous to the posterior abdominal wall. And you can find this only in intraperitoneal organs. So if you have an organ that's entirely inside the abdomen, then this organ is covered with visceral peritoneum and is connected to the posterior abdominal wall with a mesentery.
Now, let's think functionally. Why do we have that connection to the posterior abdominal wall? Now, we have a few things to consider. We have the fact that if we've got an intraperitoneal organ and we've got a mesentery, kind of like a tail holding it back, we've got a little bit more freedom of movement in these organs. So that's something to consider when looking at structures that need to move. But additionally, we do need this connection because we need some way of the nerves and the arteries and the vessels getting to these organs. And what they tend to do in the intraperitoneal organs, the ones with a mesentery, is they travel through this mesentery. And the way they do this is simply because the mesentery itself is a double layer of tissue that's folded onto itself by the movement of the viscera, and through that it's compressed the artery and the nerve through it, and that's simply the way the blood supply and the nervous supply gets to those organs.
Exactly. And just a very tricky question. How many abdominal organs can you find in the peritoneal cavity? And just take a few seconds to think about that, guys.
So we're going to give you a few seconds now, and we might give you a bit of thinking music to have a think about this question and come back to us in 2 minutes or so. Okay, so if you were listening at home there to the online podcast, you would have heard that music, so you would have had a good 3 or 4 minutes to think about the answer to Manda's question. But if you're listening online on YouTube or something, YouTube keeps telling me every week to take the music out of the show, so that would have been edited out, and there would have been some awkward direct segue between the question and what we're talking about now. So I'm going to leave it to Manda to wrap it up with the answer to this question.
Okay, thanks, Ben. Now, my question was, how many organs can you find inside the peritoneal cavity? Well, the answer to this question is 0. There are no organs inside the peritoneal cavity.
That's very strange, Manda. Tell us why.
Exactly, because the peritoneal cavity is found between the parietal peritoneum and the visceral peritoneum. And the abdominal organs, they are either covered with visceral peritoneum, and this makes them outside the peritoneal cavity, or are retroperitoneal, so they are actually merged with the posterior abdominal wall, and they are completely outside the peritoneal and the abdominal cavity. So just briefly, intra-abdominal organs can be divided into either intraperitoneal or retroperitoneal, and intraperitoneal organs are usually covered with visceral peritoneum completely on every side, while the retroperitoneal organs are covered either only, like their anterior aspect is covered with peritoneum, while the other sides of the organ are within the posterior abdominal wall. Just a few organs are termed secondarily retroperitoneal organs. So during development of the human, these organs start as intraperitoneal, covered with visceral peritoneum, but after some time they become merged with the posterior abdominal wall, and they lose their mesentery. And a good example of that is the ascending and the descending colons. Early in development they have mesenteries, but later in life, during adulthood, they lose their mesentery. But sometimes, due to some congenital abnormalities, they might keep their mesentery, and this causes problems later on.
Okay, so that's about the end of this show for our little segment on the abdomen and a few things that we found quite interesting. Now, throughout this show, this particular episode, we had two questions. We had one at the start about, some sort of song or anthem, and we also had one of Manda's special trick questions. Now, if you feel that you answered those questions sufficiently at home, or maybe it wasn't a sufficient answer, but maybe you got close. Maybe to Manda's trick question, instead of saying 0, you said 1 or 2. That's a reasonably good answer. So maybe what we're going to do is we're going to encourage that you email us, and maybe you're good enough to be on our show. If you were close, maybe you're good enough to be on our show. So email in your answers to the national anthem question, what national anthem you think it is. But also, if you got Manda's trick question, right or close to being right, then email as well, and you might be good enough to be on our show. And we do encourage that you come in. So get on board, clinicalfocus@gmail.com. Give us an email, or, the YouTube group and the Facebook group, pretty self-explanatory. Just chuck Clinical Focus somewhere into the address bar. I'm sure you'll get it. And get involved, because this is a student project. We encourage everybody, and everybody's going to be, available to come and talk about something that interests you in medicine or even any other topic. So, we're going to leave it with that. Thanks, Manda, for your insight today and some of your interesting questions that you raised. And we're going to leave you with a song. If you're listening at home, you won't have this song, obviously, because it's on YouTube. But we're going to leave you with a song. Yeah.